Hello and welcome. We have a very important show for you tonight. I think you'll find it very, very interesting. We're looking tonight at the link between depression and chronic disease. And specifically tonight we're looking at depression and Parkinson's disease. There are a lot of unknowns, but there are some knowns. And we're going to talk today with a neurologist who can tell us a lot about the knowns. My guest tonight is back. She was on a few years ago, and we had a fascinating interview with her then talking about the non-motor symptoms of Parkinson's. And of course, depression is one of those. So we wanted to go into more depth. Dr. Okeanis Vaou is my guest. She is a neurologist, as I mentioned. She is also a movement and sleep disorder specialist. She works at the Noran Neurological Clinic here in Minneapolis. She's also the medical director of the American Parkinson's Disease Association, the Minnesota chapter. She is a physician who has published lots of articles, and when I read her bio, I was intrigued. She's published and done research on Huntington's, on stroke, on epilepsy, of course on Parkinson's. She lectures around the world, and she's a real asset to our community and our state here now in Minnesota. You've been here 2.5 years?
I believe so. Now it's moving on to 3 years almost. It's incredible how time flies.
Yes. Well, welcome back.
Well, thank you for having me back.
You know, when Robin Williams died this past summer, I really wanted to do a show right away, and we couldn't do it right away, but that really was kind of the impetus to understand more how depression and Parkinson's, which it turned out that he had been diagnosed with, are linked, and the horrible consequence in his life of suicide, but just the tough situation of having a disease that you know is going to be with you for the rest of your life. It's not a unique kind of thing. I think the numbers of people with chronic disease in our country is significant. Do you have any idea how many percentage-wise of the population do have a chronic illness?
Chronic illness, or I mean depression, and what's the percentage of
just
depression
a chronic
and
disease in general? Do you know any statistics?
No,
on that?
that would be hard for me to know. I can't really come on a number right now, but I can certainly tell you how many patients with Parkinson's disease we feel that we've seen that have depression, and we're thinking that probably anywhere around 25 to even 45% of patients who suffer with Parkinson's disease have depression at a certain stage. We also have been studying depression as being diagnosed even before the motor symptoms appear. So before the diagnosis of Parkinson's disease, even 10 years before.
That's very interesting.
Yeah, it's so one kind of ponders and wants to think, is it the disease that causes depression? Is it actually the fact that a patient has just learned that he suffers from a chronic neurodegenerative disease that causes depression? These are still answers that we're looking at, but we're getting closer to probably believing that both of the situations are true here.
So it possibly could be that people who have depression are more at risk to have Parkinson's?
You can no, I think you can
That would
probably
be
not
it.
say
Okay.
that. But what you can say is patients who have Parkinson's disease are certainly at higher risk to have depression.
And some of them had the depression prior to the diagnosis.
Prior to the diagnosis, prior to what we call the motor symptoms, so the tremor, the stiffness, the unsteady, the balance problems. So usually depression or anxiety we see starts prior to these symptoms.
I was wondering when I was thinking about the diagnosis if depression would come kind of early when you know you've got a tough tough condition, or would it come later as your symptoms progress? But I'm guessing it can show up anywhere on that.
And that is very true.
Continuum, right?
That's very true. Yeah, because what we have found and what we know so far is that it is the mechanism of Parkinson's disease, the actual disease that causes depression. We know that there is a depletion of dopamine in the brain. The patient's brain, the cells are producing less and less dopamine. That has and it causes the motor symptoms, but also depression, because it affects pathways that lead to depression. So it is a cause of the disease. It's also a cause of someone knowing that they have a chronic disease.
Yeah, so it's both and. When you talk about dopamine, and if you would be talking to a school age group, it's a brain chemical, we know that, but can you tell us a little bit more about it? Because to most of us who are not neurologists, it's quite a mysterious thing how not only dopamine, but serotonin and some of the other brain chemicals work. But can you just give us a little basic, maybe
well, that would be,
grades?
yeah, I'll try to do that, even though it's quite hard, because like you said, dopamine is a neurotransmitter, what we call it's a substance in the brain that basically helps cells communicate, but not all cells, only certain cells in the brain, mostly what we call basal ganglia, and that's what these cells have that disease, and they start to die slowly. Now they produce dopamine, and it's kind of like their language of communication between those cells. So they control a lot of functions in the brain. Therefore, the patient's movement and coordination, and also mood, and autonomic functions of the body. So it's not just one specific, how should I say, function that they do. It's very vast and very difficult to explain in, like you said, in simple layman's terms. But certainly dopamine is involved in a lot of things in the brain.
When we think back to Robin Williams' death, do you feel that when you're talking now to a patient who you're telling that person that you feel they have Parkinson's, do you think someone of his stature and fame in life, when people know he had it and committed suicide, do you think that makes people feel more hopeless when they are told they have Parkinson's?
I think what happened with Robin Williams' death is that it brought out the information that depression and Parkinson's disease are very well connected. And we know that depression was undertreated and remains undertreated in patients with Parkinson's because everyone focuses on the motor symptoms, and they don't really look into deeper to see what else is going on. So I think in that sense they should be hopeful, because it brought to the surface the awareness of depression. So I think that's a good thing. That's something, some good things that came out of it. Yeah.
So more awareness is a key thing, isn't it?
For more studies, for better treatment, and for even the patient to know, you know what, I'm feeling depressed. Maybe I should tell my movements or neurologist that I feel depressed, because maybe it's related to Parkinson's disease, because he knows now that it is. Before he wouldn't know that. Yeah,
that to me is a good, important thing. Do you think most neurologists ask their patients if they are feeling depressed, if they're feeling low?
There have been studies on that, and the answer is no. So again, since we know that it's undertreated and underdiagnosed, that probably means that they're not asked. Like I said, most of the patients, their main symptoms are the motor symptoms, and they're
focusing on that.
They're focusing on those.
That's what they're asking the doctor about, and that's what. Yeah, it's kind of a vicious spiraling, isn't it, in terms
It
of...
is, and it is. And one should think that in every visit there's so many questions to go through because there's so
Yes.
many other non-motor symptoms, symptoms that you don't see. So you have to go through a big questionnaire to ask the patient. But yes, depression should be one of them.
When you use the word depression, I think, again, you know, like almost every medical term, there are different ways to define depression. But what are the key elements of depression that you look for as a physician?
And so in a patient who's depressed, you want to ask questions such as, how do you feel sad? Do you feel more sad than others? Do you cry all the time? Most patients with depression may sleep more, sleep less. They have insomnia. They have trouble with their sleep. They also, with their appetite, they may not have an appetite or eat more. They have problems concentrating, or that may lead to problems with their memory, even though they may not have dementia, but because they do not, let's say they're not really in tune with what's going on because they don't have the motivation, they don't pay attention to what's around them, so that leads to not really registering, and their memory is not that good. So these are some simple signs, and of course feelings of fatigue and lack of energy and motivation. These are also signs of depression.
And you don't have to have all those things to be diagnosed with depression, do you? I think I've read 5. If you have
There's
5 of the 9 or whatever there are, that qualifies you for probably being depressed. One of the good news things I've learned about depression through the years is that for most people it's treatable. And would you say that that is true for most people with Parkinson's, that they are able to get the depression under control if they get on meds and also perhaps do therapy?
Yes, I would say for most of the patients. However, each patient is an individual and we can't generalize, but it has to do with how bad the depression is and how late in the disease are we dealing with other problems as well that may be contributing to depression, such as sleep problems. But yeah, overall, it's in patients with Parkinson's, it is very common to treat, or when we see that we start treatment, they respond pretty well.
Are there any tough combinations of meds that make it tough to treat Parkinson's, interactive negative interactions between the meds for depression and the meds for Parkinson's?
Well, actually, this is a great question because I get it all the time in the office. Because the answer is no.
That's good, because sometimes in situations somewhat like this, it can be a real complication.
Yeah, the answer is no, but we do get a lot of phone calls with concerns about some interactions about the medications, which actually do not really is not the case, and we just have to approve that and actually confirm with the patient that there is no problem. So, yes, we get that a lot.
You monitor the meds they're on, and
yeah, of course, yeah.
Do you feel that it's important to have talk therapy or counseling along with the meds for most people with Parkinson's?
Yeah, it's a multidisciplinary approach always. We're talking about medication, we're talking antidepressant medication. We mostly use what we call SSRIs, which are very helpful, and cognitive behavioral therapy can be used, and other therapies. And I also want to stress that exercise is a very important therapy. To begin with, it's important therapy for Parkinson's disease, but also helps with anxiety and depression, treatment of anxiety and depression. So that's another reason why patients with Parkinson's disease should exercise very regularly. Understand that may be a problem, though, if they are depressed, if they lack motivation, which comes with depression. So
It can be tough, can't it?
It can be. It
because
can be
if your
very
energy
difficult.
is low because of the disease,
And the depression.
and depression causes you to feel more apathetic.
Mm-hmm.
To get out, I mean, even people with no chronic disease and pretty high energy have trouble exercising, and
Yep.
talk about the hardest step is getting on those clothes and going out the door. And so I can imagine that it's a double whammy kind of. But there are some really wonderful benefits, just not even looking at depression, but for Parkinson's patients when they exercise regularly too, aren't there?
Correct. And this is one of, I think it should be considered, for the patient, they should consider it like another type of treatment for them, along with their pills plus exercise. We've seen that it's probably the only thing at this point that we know that slows down the disease. It may have that potential. So it is
That's
very important.
huge.
It is huge.
It's huge. Do most people that you see, do they seriously hear this and become really good exercisers?
Mm-hmm.
Do they?
I have many patients that are very religious to stick to exercising, and they usually exercise 4 times a week, maybe about 20, 30 minutes, and they do so well. And they're so proud of their exercising, being able to exercise, and they feel that I actually had a patient who stopped exercising for some reason for about a month, and he felt so much worse. So he did acknowledge, and he realized that he has to be exercising all the time and not stop.
So that's got the benefit then of helping with the depression as well as the symptoms
The motor
of the
symptoms,
disease.
yeah. Mm-hmm.
It's very hard, I'm guessing, to be a doctor who can't tell people exactly why they got this disease and can't tell people that you can cure this disease. But to at least have the exercise as a positive, that's got to feel good too for you as a
Yeah,
as a
and
treating
it's not just the
physician.
exercise. I'm always telling my patients that we have so many medications right now versus when comparing to, let's say, 30 years ago when we didn't. So things are moving forward, and there's a lot coming out in the next few years, hopefully. So there's a lot to hope for.
I want to ask you a little bit more about that later because, that sounds really important. One of the things I read, and I just wanted to double check with you on this, is that some people with severe depression have electric convulsive therapy, ECT, and I read that can actually reduce some of the motor problems that go along with Parkinson's. Is that correct?
Well, the ECT has been, the studies that have been done in Parkinson's disease and ECT are older studies, and there are only a few studies. There are only a few what we call case reports. So we don't have these hundreds of patients being tried on ECT and see how well they responded. I can't really answer that question. We don't have enough data. And it's not very common for a patient with depression to be undergoing ECT. From what I've read, the few case reports, yes, there were some benefits, motor benefits, but they weren't much better than medication or something to think about as treatment.
Okay. I've heard that shock treatments are coming back into use more than they had been for many years. But again, it's probably not a big percentage of people that have them.
I would
Disagree?
No, I wouldn't disagree. I would just leave that for a psychiatrist to answer the question.
Yeah, it's a complicated one. There's some information that I wanted to ask you again about, but that was interesting sounding in terms of differentiating between apathy and depression, and some of the things going on in the brain that can cause a person to feel apathetic. Is that something that goes along with Parkinson's also the apathy symptom?
Yes, so apathy, unfortunately, is another symptom, non-motor symptom of Parkinson's disease. What apathy means is the patient basically does not have and does not enjoy anything in life, does not get any joy from things that he used to. And we know that apathy is mostly because of, again, dopamine. So dopamine is decreased in his, the levels are decreased in his brain. We know that dopamine is the feel-good medication. It's also involved in what we call the reward track or pathway. So basically something that we do that gives us joy, anything from patients who have addictions or gambling, they get that reward feeling of joy, or even just enjoying something you like a good movie or a glass of wine, things like that. That's where dopamine is involved in that pathway. So now, when dopamine is no longer there or is decreased, the patients don't get that feeling of pleasure anymore. So it's not that they don't feel, it's they can't feel.
Oh, that's an interesting way to put it.
It's basically patients, other people may view them as they don't care. Again, it's not that they don't, they can't. So
and that would be very important, wouldn't it, for the family members to understand?
Right.
When you mention not getting pleasure, one of the things I've heard is that people who maybe used to have a very good sexual relationship no longer get pleasure from that.
Correct, yeah.
That would be another example, right?
Yeah. And we know that it can coexist with depression. Apathy is a symptom of depression, but not the other way around. If somebody has apathy, it doesn't mean that they have depression. But in Parkinson's disease, it's very hard to distinguish between the two, and we know that they overlap and coexist. So it's hard.
So many tough symptoms go along with Parkinson's. But not everyone with Parkinson's, it's important to mention, has all these symptoms that you're alluding to either, right?
Correct. Yeah.
We've just got about 4 minutes left. I wanted to come back when you mentioned there were some hopeful things on the horizon. Can you tell us a little bit more? I know you've been at some conferences recently, and so you're hearing, I'm sure, some new studies and...
I'm hearing a lot of exciting things. I would just like to talk more about the things that we are sure that are coming out. There's 2 medications waiting for FDA approval, most likely. One is most likely going to be approved in January. The other one is February 2015. The one is, they're both levodopa medications. One is a levodopa carbidopa intestinal pump, which it's like the insulin pump. So basically, it will be releasing dopamine constantly, levodopa constantly. So there will not be any fluctuations entering the brain. So that is a positive. Trials have shown very positive results in decreasing the off time and also decreasing abnormal movements such as dyskinesias. Then there's another one coming out, which will be a pill, and it's a long-acting levodopa medication. Again, they're saying that there's, in the trials, it showed less off time and less dyskinesias. So can't wait until those are out so that we can start trying them.
Soon. One of the things that, as a layperson, that I think sounds so hard is that as people take levodopa-related meds, over time, they don't work as well. And so...
Well, that's not exactly what happens. No, what happens is they may feel that they're not working well, but it's not because the body is getting used to it. It's basically because the brain is producing less dopamine, therefore we need to supplement more.
Oh, I see. That's an
very important
way
point
to understand. But they need more then.
Yes,
so
because they're producing more. Less, right? Dopamine, yeah.
And will these 2 pills help, or these one's not a pill, but these 2 new things on the horizon, will they help in that regard then?
No, they will not. They do not provide, they do not change the progression of the disease. But they may help with side effects, and they also help with how much off time the patient is. So how much off their medication they are during the day.
So they can be off longer.
So they can be off less. So they remain on their medication for longer, so that they don't have periods where the medication has worn off between the next dose. So they don't have those fluctuations on and off, as we call them.
Okay. Well, so those are two things to look for in the next few months. We're taping this in the beginning of November of 2014, so that's coming up soon. Well, we want to give you a couple of resources to look for and to look into if you want to learn more. As I mentioned, Dr. Vaou works at the Noran Neurological Clinic. You can learn more about that clinic and her work by going to noranclinic.com. And then the American Parkinson's Disease Association, the Minnesota chapter, you can learn more about the national chapter and the Minnesota chapter by going to apdaparkinson.org. So two good websites to check out. I know we've covered a lot, and it's a complicated topic tonight, so they may be very helpful to you to do a little more reading. Well, thank you so much for coming down. You just flew into town tonight, so I especially appreciate your being here and learning from you, and I'm sure the viewers will find this very, very interesting and helpful.
I hope so.
So thank you, Dr. Vaou.
Pleasure to be here.
Good. Thank you for being with us. I'll be back again next week. Until then, have a good week.